Lahane sir, is sir's case ready?
Yes, we are ready with our next case.
Yes.
Next up, we have Padma Shri Dr. T.P. Lahane with us. It's such a overwhelming thing for us to have him here with us operate for the live surgery. Today, he is going to operate on a 72 years male, diagnosed with both eye cataract, with right eye cataract as NS3 cortical PSC. And the patient is planned for a 20.5 diopter IOL. All prepared for the surgery. Over to OT number 1, please.
Perfect. एक मिनट देखता हूँ क्या है मार्कर है.
So welcome Professor Dr. Lahane sir, and we are very honored that you are going to showcase your pearls with us.
इसको लगाया है ना ये. अच्छा इसे कुछ नहीं होगा. ओके ओके ठीक.
Yeah, we can see the microscope view.
Yeah.
हाँ ठीक है फोकस. नहीं नहीं हो गया. हाँ फोकस रहेगा नहीं ये फोकस. हाँ
it is focus, sir.
क्या हो रहा है 3D है क्या.
Yeah. Good morning, Dr. Lahane sir. It is nicely focused and centered.
Good morning. Good morning. Good morning.
Good morning, Dr. Bhalla here, sir.
Yes, I can recognize your wife.
Yeah,
Bhalla, sir.
yeah.
And
So with me,
Vardhaman is also there.
Yes, yes, sir.
अरे फिनेकन है क्या अपना ये है क्या. नहीं ये अपना ये क्या है. अच्छा मार्किंग के लिए है. एक मिनट. हाँ.
So you're going to demonstrate this thing, advanced monofocal toric IOL implantation, sir?
Yes. So I am just you can see the blue line. I am marking. And
So, sir, you will be showing us basically Vivity toric IOL.
Okay. So लिया है. क्रिसेंट ब्लूरेक्स है क्या. ब्लूरेक्स है तो दे दो. ट्रिपैन ब्लू नहीं पिनोकेन है. हाँ रेड ब्लू. हाँ मिल सकेगा इसमें. हाँ Okay, the other one. Crescent. So Vardhaman and Bhalla sir, I am operating.
Yes,
crescent.
sir. We can see very clearly, sir. It's
Yes,
beautifully. Yes, sir.
क्या आर्टरी छोड़ दे. क्रिसेंट है ना. आर्टरी एक दे दो. हाँ डायरेक्ट ये दे दो. 2.8 दे दो. बाद में 1.1. So आप इसमें देखते रहिए लाइट में. कुछ भी है तो मुझे मुंह से बोलिए. ब्लूरेक्स दे सकते हो. ब्लूरेक्स ओके. आप लाइट में देखते रहिए. कुछ भी हुआ तो मुझे बोलिए. हाँ ओके. नाउ आई एम डूइंग द सिटिंग टेम्पोरल and doing the incision. This is 2.8. I go parallel to the cornea. 1 point you can say 5 inside, and then I go down. So this is the tunnel I have made, and Dr. Ragini is assisting me. I am lucky. Now this is the MUR blade I use for the side port. This is the side port, and then the on the other side now I am making the other side port for my other equipment. Blurred. So I am using the, I can see the cataract is dense and the capsule is not seen on the, you can say the nasal side. So I am using the trypan blue. Trypan blue. Now normally what happens if you keep it for 17 seconds, that will stain. If it is a pediatric cataract, it is said that it should be kept as more than 1 minute.
It.
So that the possibly the pediatric cataract that helps. But in the adult, 17 seconds is sufficient to stain. And if it is intumescent, then always better to more than 55 seconds. So that the capsule, it is said that then you will not get the Argentinian flap if you keep it for the 1 minute in the intumescent cataract. चाचा आपको लाइट में देखना है और आंख को नहीं, आप दोनों जो है ना हिला रहे हो, आपको हिलाना नहीं है, आप हिलाओ मत, आराम से सो जाइए. So now the I'm just putting the visco. हिलाना नहीं चाचा, आप हिला रहे हो जरा, थोड़ी इधर हिलाना नहीं है. Now I will do the rexis. Normally I use the 26 number needle, and the Ragini always make for me. So can see the, I go in the center and I create a radius. And then the according to that you see there is hypotony. I will put an visco again. If there is a hypotony, then the circle is not proper. Put visco. I was getting smaller circle. Now you will see the easiness because just I put a visco and see this flap comes in between. So that flap you will have to again take it away from the area where you are doing the rexis. This side the capsule was not seen, so I stained it. And when I am finishing, I will finish it from outside. Do the hard dissection.
Dr. Lahane, can you hear me?
Yes.
I'm Naushir here. What do you do about these cortical, capsulocortical adhesions? Sometimes they prevent the rotation of the nucleus.
That I know because that is there on the my nasal side. These adhesions where their adhesions are there. So I will do more hedro slightly, so that I will try to separate it when the adhesions are there.
Sometimes you can separate it, inject it with a viscoelastic and separate them with a blunt instrument.
Good idea. That can be done. You will have to. So these are the adhesions you can see there. And so I am trying to separate it out. Huh. This is the pinocaine I am using because the pupil is dilated slightly earlier. Visco, right? So I will put a visco.
You get a lot of.
Sir, I think if you put, I mean, you can put, of course, phenocaine at any point in time, and it's a great drug because it causes intraopmidriasis. But would you suggest that we put it right in the beginning, or because even at that time the pupil was not as well dilated as we would want it to be?
Yes. Namrata, I know. Namrata, I have put a phenocaine so that will maintain minimum whatever the pupil is dilated now.
Yes.
So that I did it.
So which machine are you using, sir? Centurion?
Centurion machine.
Centurion machine is being used. Okay. Centurion
So
with active sentry.
Active sentry machine I am using, and in that the parameters.
So with active sentry, the advantage is that actually the sensor has moved from the machine to the handpiece itself. So whenever there is a surge, then the surge gets mitigated as soon as it is detected at the level of the handpiece itself.
Sensor in this case at the tip of the phaco tip, and therefore the sensing is much more accurate, and therefore you can avoid a surge in these cases. That is what active sentry is all about. The handpiece, although it's much more costly, but sometimes it saves you in many situations.
And the gravity independent system also takes care of being able to operate at low intraocular pressure, which is a great boon to patient with coexisting glaucoma.
Yeah, you can lower your intraocular pressure and still maintain a good chamber.
So now I am the.
I just want to.
I have made a piece on one side. I will rotate because I was not sure about the separation. Now it is separated.
Yes, sir. We could see a nice separation.
Chop. I have chopped it. Piece quadrant. So I have removed the quadrant so that the I have made another quadrant now.
Yes, sir.
I find great utility of torsional mode at this stage once your fragments are separated and you just have to eat up the pies, because unlike longitudinal, torsional, there is no repulsion at all and there is magnetability of the pieces.
Chamber maintenance also.
Yeah.
The followability is much better in these
Excellent.
cases.
Yeah, magnetic followability. Your pieces just remain glued to the tip as you see here, and there is hardly any repulsion of the pieces.
Absolutely.
Not at all. There is no any repulsion. And you will see this was the piece where it was attached to the capsule.
Very nice.
I have removed that.
Beautiful, sir. So I think
Very
it was-
nicely done, sir.
Very, very nice.
Absolutely.
And
The
now,
whole audience is appreciating, sir.
thank you very much. And now I use the AC maintainer.
Why do you use an AC maintainer, sir?
Because that is चालू कर रहा हूँ ये मेरा आदत है तो because we operate so many cases, because of that every time
You don't prefer a viscoelastic while doing IA to maintain your chamber. You just want to maintain your chamber with
yes.
can you?
I maintain it by the this one AC maintainer, and this is my aspiration cannula that I have made in '96. So that I use. You can see the.
Yeah,
I want to show you the adhesion of the capsule. Can you see?
You never use a bimanual, sir.
Huh?
You never use a bimanual
I
instrument.
use by manual. See this, these were the adhesions of the capsule, and that light में देखिए. Can you see this is the adhesions of the capsule, and that has broken the entry capsule. I use bimanual also, sir.
Has the rexus seems to have extended a little at
Yes, that is because of the adhesion, sir. I told you there is a adhesion, so I use the blue rex. So that time I was knowing.
anyway,
there
it's
is-
very well managed, sir. With the
Yes, sir.
extension of the
Very beautifully managed, sir.
the flap
this is-
sign, you know, this flap sign in these cases is very important.
Yeah.
Yes,
If
yes.
The
if
flaps
there's
are
a flap, if the flap keeps flapping, then it's okay because it's not extended to the posterior capsule, the
Yes.
tear.
Flap motility sign. You see, I have taken it from other side.
Yeah.
So that is what is the advantage.
Yes, absolutely. So as Dr. Shroff sir has said, the flap motility sign described by Dr. Rohit Om Prakash sir has
Yes.
given us a lot of peace of mind, because now we know if the
Filament.
extension is there or not, and here we
Yeah.
can see that it is mobile,
It's
so we are
and
quite safe.
As long as the flap is mobile, you are safe. It stops flapping,
Yes.
it goes to
Yes.
there's extension to the posterior of the posterior capsule.
So I think
Excellent.
everything I'm polishing the entry capsule. The length.
So Dr. Shroff sir, how much of percentage of your cases have now shifted to the EDOF lenses like VVT?
Excuse me, what?
In my practice,
Yes, sir.
What
in
were
my
you?
practice, in my practice, I use near about, you can say, the more than 50% EDOF lenses,
Oh.
25% trifocal lenses, and 25% monofocal lenses. Badal.
I think everybody has shifted to EDOF lenses quite a bit because it has no dysphotopsias and there is no
Yes.
negative side to it. It almost behaves like a monofocal lens, but
As it
gives,
is, yes, very
but-
as
and
it
gives
is-
you a good depth of focus, which is good for computer work, although it's not good for reading, but still very good for computer work. So, and it has no disadvantages. The chair time is almost nil compared to a monofocal lens. I mean, you can just implant it
Light में देखिए,
without even counseling a patient about the EDOF lens, about its disadvantages.
Allow me, please.
Now we are seeing the
Implanting the lens, you will
implantation of the VVT toric lens. You can see that very
So this is a
controlled.
monofocal toric on the Clarion platform, and because this I use Clarion platform, no negative photoxia, nothing. So very good lens.
But this is a VVT lens, sir?
No, monofocal toric.
This is a Clarion lens.
Clarion, yeah.
Oh, this is a monofocal.
So the Clarion,
VVT toric.
yeah. So the Clarion material
In
has,
VVT, I think you get the binocular, this apna near vision also,
yes.
and those patients.
Sir, have you not put on the DMM system? I thought you were going to show us the Varion system on this.
Variant is there, I will show you.
I think if you see the Clarion lens, the injector of the Clarion is again quite, when you inject it, it's absolutely effortless. It is carbon dioxide driven, so you just have to press the button and very smoothly the lens unfolds inside the anterior chamber. There are no jerks. It's a preloaded lens, so there are no scratches. You don't have to, no one has to load it beforehand. The microbial contamination is also less with the preloaded lenses because they're already loaded, and all the problems which may occur during loading are obviously obviated. The optics are much more, are much better as compared to
Professor
the
Lahane,
previous
you,
platform.
you have marked the lens with gentian violet.
Yes, this is marked lens and I'm putting there only.
Yeah, but if you use a DMM system, do you still use a marking of the limbus? Because
Yes,
the DMM system is supposed to give you the exact position of the axis of implantation.
I'm going with the variant only. So,
No, I can't.
Actually, no, sir.
I'm
What
going to
happens
put
is
like a
Varion,
Varion.
it doesn't come here if you don't focus onto the screen, the monitor. It won't come in the microscope.
It comes in the
We
microscope.
can't see the. We
now
can't,
this is the,
It comes
this
in the
is
microscope. It
position
comes
now.
in,
so
comes
we
in
can't see the Varion overlay on the microscope here, sir.
Can
you
but
put Can you
it
put the
is-
Varion only on, please?
I am only able to see because that is seen in the TV, not on this
So
one.
can
But I
the-
have made this marks also to see, and accordingly I am putting the lens.
Which microscope are you using?
Zeiss
I'm-
microscope.
Right.
Are you using Artivo?
Yes, this is Artivio. So I think, sir, it's a very brave step to implant a toric intraocular lens in a case where the rexus is already extended and the axis is also onto the same place where your extension of the rexus is.
Huh?
So the axis is not in the same plane where the
No. Axis is not in the
Sorry,
same plane.
axis is on the opposite. Thank you.
Axis is 6 degree, and the extension is in the, you can say 150 degree.
Yeah, so because
It's
of that, we
almost-
are stable and safe.
Yeah.
Yes,
Because
it's
of the
stable and safe. If it is
orientation,
in the
yeah.
same degree, then we should not. But if it is not in the same degree, lightment. So if it is away from that, we can definitely implant the.
So suppose it was in the same area where your extension of rexus was.
Then we should
Would
not.
you have used the same lens, or would you have used a three-piece?
I always keep a standby and I use a monofocal lens. in the
Monofocal.
system.
I think it's done. And here, fortunately, the haptics are almost perpendicular to the area of the
Yes,
torn axis, so
yes.
lens is
Haptic
very well
is
stable.
here. Haptic is here and
Yes.
here, so if
Exactly.
nothing is there in the this area where the capsule is extended. Haptic.
So actually the Artivo, the Callisto overlay comes only on the 3D screen. It does not go in the output feed. That's why we can see everything here on the Callisto,
Yes.
but you will not be able to see the Callisto
Ah,
overlay
there
over
it is
there.
not right.
So I think we'll move on to the
Yeah,
next.
thank you so much, Dr. Lahane sir, and I
for a
think
very good,
sir deserves a
Dr.
round of
Ragini is
applause
with us.
for
Thank you,
such a beautiful
Gaurav.
surgery.
Thank you, Gaurav. Thank you,
Thank you so much for coming to our
Namrata and
Center for
AIOS
Surgery.
and the local committee. Really
Thank you so much, sir, for an excellent
to have
demonstration.
the Rusty and Gaurav team.